Good morning and welcome to another session of the Tourette Association's virtual conference. I'm Angela Sullivan, Medical Project Specialist at the Tourette Association of America. Thank you for joining us for Suicidality and Youth with Tic Disorders. We would like to take this opportunity to thank our conference platinum sponsors, MLX and David Amundsen, our diamond sponsor, Oracle, as well as our donors and supporters for making this free conference possible. To help us continue to provide educational programming like this, please consider making a donation. Your gift in any amount will assist the Tourette Association of America in continuing to provide critical support and resources to the Tourette syndrome and tic disorder community. Please visit tourette.org/donate to contribute today. During today's session, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. I would also like to mention the slides for this presentation are available to download under the handouts panel on the GoToWebinar player. It is my pleasure to introduce you to our presenters, Dr. Joseph McGuire, Dr. Barbara Coffey, and Dr. Adam Lewin. Dr. McGuire is an assistant professor in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. Dr. Coffey is currently the chief of the Division of Child and Adolescent Psychiatry and professor of psychiatry at the University of Miami Miller School of Medicine, as well as the director of the TAA Center of Excellence. She also serves as co-chair of the TAA's Medical Advisory Board. Dr. Lewin is an associate professor of pediatrics and psychiatry and interim chair of pediatric neuropsychiatry at the University of Florida. Without further ado, Dr. McGuire, please go ahead and begin the presentation.
Fantastic. So just looking at all of our backgrounds, one thing I noticed before we begin is we all have like delightful paintings behind us. But that's not why we're here today. We're going to talk about suicidality in youth with tic disorders, and really kind of focusing on raising awareness and education, and then working together to outline a plan to respond and how to help young people and their families struggling with this. In terms of some conflicts of interest or relevant disclosures, I received some support from the TAA, American Academy of Neurology. I do some consulting for companies and put out a few books. In terms of the overview for today, really it's going to be focusing on, I'm going to be talking about prior studies that have looked at suicidality in individuals with Tourette syndrome, and Dr. Coffey will follow up highlighting recent results from the Tourette Association Impact Survey. Afterwards, Dr. Lewin will really talk about how do we translate all of this research into practice for patients and families to support them in the best way possible. And then we'll kind of wrap up with some questions and answers and talk about next steps. So to date, there's really only been 3 studies that have really looked at suicidality in people with Tourette syndrome, and I'll go through each one and then kind of summarize what we kind of know from all of them, and then talk about where we still need to kind of move forward. So in 2015, Storch and colleagues looked at a large clinical sample obtained at the University of South Florida, where Dr. Lewin is presently at, and also collaboration with folks in upstate New York. And they looked at this entire sample of, I think it was like a little over 200 individuals with Tourette syndrome, children, and also 100 individuals who didn't have any sort of psychiatric conditions, and really asking this basic question of how often do people, young people, children, adolescents, have any sort of suicidal thoughts and or kind of behaviors. And what they found is in about 10% of individuals or children with Tourette syndrome will experience, at that kind of cross-sectional time point, some sort of form of suicidal ideation or behavior. And that means anywhere from a passive suicidal thought of, oh, I wish I were dead, much more towards even in some cases, individuals who even had a plan. And this is notably higher than about 3% of what you saw in the community controls, people who didn't have any sort of psychiatric illness. When looking at those individuals who endorsed any sort of suicidal ideation or behavior, kind of grouping that together, one thing that kind of came on out was that this thought and behavior more often occurred in the context when people were frustrated or angry. So it wasn't necessarily as associated with depression, but more in this general context of mood when this was kind of happening. One thing that also came out of it was that individuals who had suicidal ideations and behaviors had a greater association with tic severity and tic impairment. So really what you're kind of seeing here is there's the greater severity of your tics and the more impairment you're experiencing, you're actually at a greater risk of having suicidal ideations and behaviors, or vice versa. One thing that kind of came out of it, going back to, how mood plays a role, is when looking at the relationship between suicidal ideations and behaviors and tic severity, that relationship was mediated by anxious, depressed symptoms per parent report. So what that kind of tells us is it's not necessarily the severity of your tics, but how much the severity of your tics can influence your mood, which then in turn influences the occurrence of these behaviors. When looking at another study that came out of the same research group, you saw a pretty similar incidence of suicidal ideations and behaviors. So depending if you use the parent or the child report, in this particular sample, it's between 8 and 11%, which is pretty similar to that 10% that you saw in the previous sample. In contrast to the previous sample, you actually see in this case that suicidal ideations are unrelated to tic severity, which could be influenced because of the fact that there's different preponderance of anxiety and depressive symptoms in that sample, or it could be unrelated for another reason. Where did that go? So it's but what you did see is it's indirectly related to tic severity and behavior. What you kind of see is there's a greater relationship with anxiety and depression. And one unique thing that this sample looked at is they also found a relationship not only between anxiety and depression, but also how well you control your mood. So, affect lability, how well you moderate your affect, as well as how well you're able to tolerate your distress. So what that kind of tells us, in the short story, is how well you manage your mood and how well you're able to tolerate distress really plays an important role in whether or not you're experiencing suicidal ideations and behaviors for young people with Tourette syndrome. So that's two studies, both out of the same research group. What does this third one kind of tell us? Well, this third one came out more recently in 2017. And what you see is they looked at a whole national sample in Sweden of a patient registry. And they looked at all people who had a historical diagnosis of a chronic tic disorder or Tourette's disorder between 1969 and 2013. So pretty wide age range. And what they were able to do is identify up to almost 600 people who had met that diagnosis. And what they found is, looking through that patient registry, almost 8% of them had one or more suicide attempts. And you even had 32 individuals who died by completed suicide in that sample. So it's again in that kind of 8 to 11% range that you saw in those previous samples, but this one is more of a broader population. One thing that they kind of highlighted that I think is important to kind of bring up, especially as we think about kind of readiness to action, is most people had their first kind of suicide attempt between 18 and 22 years of age. So really this period of adolescence and young adulthood is really a sensitive period where people are starting to really struggle with these conditions. When you look at, and they also looked at the incidence of suicide in patients who didn't have Tourette syndrome and kind of compared the two. And what you see is that people who have Tourette syndrome are at a almost 4 times more likely chance to have a suicide attempt, and a little bit over a 4 times likelihood chance of experiencing a suicide completion. So really this is an elevated risk, but when you actually adjust for comorbid conditions like depression, anxiety, OCD, that risk drops down, not dramatically, but still probably by about 1 point to 1.5 points on those odds ratios, which really tells us that overall comorbid conditions, it's not just kind of having tic disorders or Tourette's disorder, it's really about having Tourette's disorder and a comorbid condition that's kind of complicating the situation. One thing that often comes up when thinking about who might be at most risk for this it really kind of two predictors kind of came out after adjusting for everything. One is the persistence of tics beyond young adulthood. So people who kind of had tics over the course of their life, this wasn't a real issue for people whose tics went into remission in late adolescence and early adulthood. And also they found that people who had a prior attempt were more likely to have a subsequent attempt in that sample, which is what you also see with a lot of other patients who have suicidal ideations and behaviors outside of Tourette syndrome. So what does this kind of tell us, and what do we need to do to really move the field forward? While this is great that we have 3 studies on this topic to date, and hopefully more in the pipeline, one thing to really think about, in 2 of those studies, they had, 200 people or less, and they were both obtained largely from, the same clinic or same general groups of clinics in Florida. So really, how well does that generalize to the entire United States population, to Canada, and elsewhere? Another thing to kind of think a little bit about is, in one study we found that there was a relationship between tic severity and tic impairment, and in another study we saw that there really wasn't a relationship, and that really it's more being driven by anxiety and depression and these co-occurring mood conditions. So is it really more this tic severity that's kind of relating to suicidal ideations and impairment, or tic impairment, or is it really these comorbid conditions that we have to really watch out for and figure out how to best address in an effective way? And I think that larger population study tells us that having those co-occurring conditions places you at an added level of risk. And really what we need to kind of do to move forward is one, when getting diagnosed, when starting to think about how we kind of manage tics, and who's at most risk, really thinking about those people who have co-occurring mood disorders and co-occurring challenges managing mood, those people who have difficulties with affectability or lower distress tolerance, and thinking about what kind of support they need to kind of manage these urges that kind of come on up. And we'll talk more about how to bring these kind of thoughts into play through Dr. Lewin's talk later. But what I'm going to now do is turn it on over to Dr. Coffey to talk to you about the most recent results coming out of the Tourette Association Impact Survey. And Dr. Coffey should have control.
Thank you, Dr. McGuire, for a lovely introduction. So I got interested in this issue as co-chair of the Medical Advisory Board when we reviewed the results of the 2018 Impact Survey. There were a number of very concerning findings that came out, and I'd like to discuss that with you today as we think more about this topic. I'll start with my disclosures of the past 12 months. I've received honoraria from the American Academy of Child and Adolescent Psychiatry. I do a number of talks for the Harvard Medical School and Psychiatry Academy, for which I receive honoraria. I currently have funding from the NIMH for our research work. I've also received honoraria from the Partners Healthcare Organization affiliated with Harvard Medical School. I'm on the advisory board of Sky Island Trail. I've received research support from Teva and Nuvolution, and I'm also on the scientific advisory board for this group. And although I don't receive funding for this, I am a co-chair of the medical advisory board. I have received some funding for the CDC partnership talks in the past. And I've most recently, in the last year, received honoraria from the University of Florida for our Southeast Regional Consortia organization in speaking. So I'm going to start with, if I can go back here, with just disclosing that we presented this information last October at the American Academy of Child and Adolescent Psychiatry meeting. So just to kind of run through this, I'm going to show you several different versions of the findings. But again, I think this raises a red flag, sort of diving deeper into what Dr. McGuire presented with other studies. So we know that children with tic disorders have an elevated risk of experiencing suicidal ideation. So we need to look a little bit more deeply into risk factors associated with suicidal ideation and self-harm in Tourette's. Dr. McGuire pointed out and highlighted the fact that anxiety and depression may be a mediator, or anger and frustration, as we need to view these kinds of behaviors and thoughts in the context in which they emerge. So our objective was to take information from the impact survey to examine suicidal ideation and self-harm among children with Tourette's disorder and explore the impact of potential risk factors. So we looked at the data from the impact survey, and we took out, since the survey included almost 1,000 members, we took out only that data from parents about their children under 18 with a tic disorder. Dr. McGuire presented sort of larger views, some clinical setting views. So we're going to dive deeper into our impact survey, but just looking at what parents of children who are under 18 reported. And we were interested in several things as we were exploring risk factors. First of all, the central question is what proportion of these parents reported suicidal ideation or self-harm in their children? And then what about psychiatric comorbidity in these kids? There's a section in the survey that rates what are the 3 biggest challenges that parents of children have. Psychiatric comorbidity, understandably, was one of the top 3. We also looked at discrimination due to tic-related disorders, since we figured that may have a potential role in the suicidality question. And then also another important risk factor, tic-related disorders' negative impact on school experience or education. And this is maybe somewhat hard to read, but you're going to see several other versions of it. So we really took question 1, which is presence of suicidal ideation or self-harm, and looked at those whose parents reported their kids did compared to those whose parents reported their kids didn't. And you can see, looking at the question of comorbidity, that 84% of parents who reported their children had suicidal ideation also reported comorbidity as one of their 3 biggest challenges, in contrast to 72% whose parents of children didn't report suicidal ideation. And that was a statistically significant difference. We then looked at the discrimination question due to tic-related disorders. Those with those parents whose children had reported suicidal ideation, about 82% had experienced discrimination, their children had, as compared to about 57% of those who hadn't experienced suicidal ideation. And lastly, looking at negative impact on education or school experience, 92% of parents of children who had reported suicidal ideation or self-harm had had a negative impact on their school experience versus only 77% of those who hadn't. And again, all of these factors were statistically significantly different between the parents of children who had reported suicidal ideation versus those who had not. So looking at the numbers here, we had 567 parental responses altogether. So 32%, and think of that in contrast to other clinics or community samples, had their children had reported yes, that they'd had suicidal ideation or self-harm, versus 58% in those who hadn't. Looking at comorbidity is one of the biggest problems. 85% of parents of kids who reported suicidal ideation reported comorbidity had been one of their biggest problems versus 72% with no suicidal ideation or self-harm in their kids, 76% on the discrimination question versus 53% of those who didn't have suicidal ideation, and 92% had a negative impact on school of parents of kids with suicidal ideation compared to 77% who hadn't. So just in case it's too many numbers, this is the visual. This should really help. So at the top is the major issue that I want to bring to people's attention. 32% of children with a tic disorder have considered suicide or have self-harmed. And again, looking at those risk factors, 85% reported comorbidity as a risk factor or a big challenge versus 70%
Dr. Coffey, we can't hear you.
Children with tic disorders have an alarmingly high rate of suicidal ideation and self-harm. Unfortunately, we weren't able to distinguish in this impact survey about diving further into it between suicidal ideation and self-harm. And I think one of the complexities here, as many of you know, many of our patients have self-harming tics. So how much of this was intent? Was there intent to die? Was it a very non-suicidal kind of behavior, which Dr. Lewin will talk about? Or were these self-harming tics? We don't know. But we're designing soon the 2020 impact survey. So we really need to kind of separate those issues out in more detail. Rates of discrimination and negative school impact were high in children with tic disorders, and those with a history of suicidal ideation or self-harm had a 20% higher experience or higher rate, as you just saw. Psychiatric comorbid disorders were deemed the most challenging factor in tic disorder management and influenced suicidal ideation and self-harm. But the take-home point is kids with tic disorders experience an elevated rate of risk factors that we looked at associated with suicidal ideation and self-harm. Obviously, there are many, many limitations of this survey findings, including parent reports. These were not direct interviews of anyone, certainly not the children, but we do believe that further exploration of this issue in this vulnerable population is required, and we hope to, as we design the next survey, dive much deeper into this to understand this better. So with that, I'm going to bring this over to Dr. Lewin to help us move this from clinical implications and how we might become more ready to respond to our patients.
You should have control, Dr. Lewin.
There we go. Well, good morning. Still morning. Thank you all for participating. It's overwhelming how many folks are tuning in, and we appreciate it. Thank you, Dr. Coffey, for organizing this important topic, and thanks to so many of the folks on this call who participated in the impact survey, and those data are so meaningful to us and as clinicians, as researchers, to guide what are the next steps to advance intervention and evaluation. And a shout out, while I got a captive audience, to all of our colleagues who are in the ER, in the ICU, but also in the adolescent units today, because while I've been able to do CBIT and take intervention remotely, I think with not too much loss, it's the folks that are undergoing treatment for suicidality in the most acute centers that can't take a break, and so sometimes we lose track of those folks who didn't get to elect to kind of wait on their treatment. So thanks to all of our medical folks and essential workers out there. Let's see if this is the lag time or if I'm my disclosures. All right. I was told there was a lag with the remote, so apologize for that. It's not just my brain. Happy to report research funding from TAA, which I did not put up there. Apologies. From the CDC to look at Tourette research, from the Ream Foundation to look at misophonia research, and from the All Children's Hospital Foundation. Some consulting work related to Tourette from Brackett, and travel and consulting fee for doing CBIT trainings. Scientific advisory board for the International OCD Foundation with no financial support, and no financial support, but on the board of directors for the American Board of Clinical Child and Adolescent Psychology and the Florida Diabetes Camp. No direct conflicts to this research or this presentation. So since we have a big community sample and are looking at screening for tics, I was hoping to have some data to present in kind of a different type of sample, not a specialty population, even though it would still be in Florida. But the rates of tics have been much lower than expected in this large sample, and at least not enough that we can really draw any conclusions yet. We've got a few more years to go. So that lets me be the closer on this one to really talk about kind of more generally. And it's, I think, good because we do have a mixed audience of clinicians, of parents, of folks with Tourette and folks that care about folks with Tourette. So I'll try to hit on some things that apply to all of us. And I think one of those things that we should all keep in mind is talking about suicide isn't easy, and that's for all the parties I mentioned. Whether you're a parent, a peer, a provider, it's important to be able to communicate about suicide and risk, but we all find it difficult. Fact is, most providers don't ask and most patients don't tell. There's that myth out there that talking about suicide, especially in youth, will increase risk, and that's not true. It's like testing for COVID doesn't make more COVID cases. It's important to be able to talk about this with all those people, and important to ask about it. Some of the things I think, again, regardless of whether you're a therapist, a physician, a parent, a peer, it's critical to be calm, to use our active listening skills when we're talking with folks here, that we're not showing tight body language, that we're not taking notes, which is hard as healthcare providers, that we're listening, we're watching our own body language and our own cues that we're uncomfortable as well as theirs. What are they not telling us? Where do we probe? Where do we follow up? Yeah, sort of. That usually means there's something more we need to know to ask about that. What about the body language suggests that while their words are saying no, their body language is saying yes, and we need to ask more. Let me just go in there and assess real quick. It says no one who should be assessing for suicidality or high-risk behaviors. These should never be rushed. This cannot be a quick assessment. It needs to be at the pace of the patient, of the person. We don't want to make this an interrogation. We need to keep it calm and slow. We need to ask the right questions, as specific as possible without making it feel like it's an interrogation, that we're not just asking, have you thought about suicide, have you thought about death, but asking the specifics. Have you thought about this? Do you have a plan when? I think one of the things that can help even for some with style is this notion of the gentle assumption. We use it in substance abuse, we use it in adherence. Instead of saying, do you ever, when's the last time you had these thoughts? Or tell me about one of these thoughts that you've had, as opposed to, do you ever think about suicide? Sometimes setting it up as though it's an option, as opposed, it can start the conversation going. And again, getting very specific. Even if they deny a general question, ask specific follow-up questions. They might say no to they've never thought about it, but they might have written a note. They might have engaged in cutting, even if they say they don't think about death. So it's important, just like when we do a Yale TIC assessment scale, you start general, but you also go through the checklist. It's important to go through the specifics and to normalize. I think it's, again, that this feels human, this feels less clinical. We want to normalize that adolescents, the young folks, will have catastrophic thoughts, that these are not unique, and we want them to feel comfortable sharing. All right, I'm moving slowly through these. The next thing I wanted to talk about was risk monitoring. It's important to get specific here as well when we're talking about what goes into a risk monitoring assessment. I'm presenting it more from the clinician point of view, but these are still the type of questions that I want to know as a family member. I might go through it with a different style, but the things the areas I want to assess, and in addition to just the content of having a thought about death or dying. When we talk about ideation, we're talking about thoughts, and we want to get specific. When was the last time the person had these thoughts? Was it currently? Was it now? Was it over the last 24 hours? Was it a month ago, a week ago? In relation to that, what's the frequency? Is there these fleeting thoughts that come in the context of a tough event, or are they episodic? What's their intensity? Are they strong, kind of always in the front of the mind? Or are they kind of background thoughts that pop up only occasionally? And related to that, how much disruption do they cause? So those are things clinicians are looking for, and family members should look for too, and looking for changes in those things as well. Intent is really about how much folks want to die. It's when we talk about the non-suicidal self-injurious behaviors, the main differentiating factor there is there isn't the intent to die, even though there might be the intent to harm. That's an important question to ask, as well as the other side, how much and for what reasons might someone want to live? Because those, well, you'd think they're mutually exclusive, they really aren't, and it's important to differentiate. Next is to get into the idea of plan. Sorry about the plane. Does the individual have a specific plan? Have they written a note? Have they identified a method? How specific? Relatedly, what's their access? Asking those things specifically. Hopefully, they don't have access to firearms, but access to pills, access to chemicals, access to a vehicle, whatever means they might have considered. How specific have they gotten in terms of planning a location, planning an attempt? Is this something that's a rough idea, a loose idea? I've thought about just ending my life, or I've thought about going here with this and doing that. The more specific, the more concerned I can be. Other warning signs, I think, hopelessness, burden to others, this perception that we are a burden to our family, to our peers, that they're feeling increasingly disconnected or sad. Bullying, of course, would go along here, in person, and of course cyber is just as problematic these days. We also want to assess in the risk assessment protective factors, getting a sense of what the individual feels that they're good at, what they have to offer, and who supports them, who they can turn to. Do they have someone that thinks they provide meaning to the world? It's also, I think, related to that and some of the others is to assess what they feel might change in their life for the better. Are there things they think could be improved? This is circling back to that hope, but can they identify some of those factors? All right, sorry about the colors on this. At least I'll talk long enough, hopefully, that we can take a look. So this is what Barbara was talking about, and it's gained media attention in the last decade, I think, significantly that it's being discussed more and more among clinicians and among parents and among schools. This notion of non-suicidal self-injury, and again, that separation is the intent. The intent is to harm, not to die. This can be things like biting, scratching, cutting, hair pulling, burning, unfortunately. As Barbara said, it gets blurry in our patients because some tics do cause self-injury. So it's, I think it's, sometimes our patients will endorse this, but not with the intent to harm. It's a tic. So I think the intent really helps separate that. When we think about why we care about non-suicidal self-injury, in addition to the fact we don't want our youth, or adults rather, hurting themselves, it's this notion that these behaviors are an increased risk factor for suicide, and probably because if we lump them all together, they represent a general poor coping strategy, a poor way of dealing with stressors in life. It could be a sequential step, but it also could represent a little bit of the same thing. Deficits of problem solving, which we know can be, if we think about our Tourette iceberg, a problem in Tourette that could be amplified, especially under situations of stress. So I think it's important to assess if this is going on and apply some of the principles above of, as much as possible, avoiding judgment, asking the same calm questions, even though as a friend or as a parent, these could be very alarming when you first learn that your child may have taken a razor blade and discreetly cut. If we think about the reasons, gosh, you know, I'll be up for some Nobel Prize when we figure this out, but it's just to hypothesize we've got poor coping strategies, that this can be ways of letting out anxiety, stress, tension, depression. Certainly, I think the biological is a theory. Does it release endorphins or produce a feeling of euphoria, or at least release after the event? And there's the hypothesis of a social function too, whether it kind of produces a call for help or calming or attention. No one's saying here that these are not folks that are suffering, but there might be some secondary gain for getting on the radar. To say this is serious. This is seriously affecting me. Like the Mac for my slow advancement here. These are the next couple slides I want to just highlight are general. It's much more important to look at the specific level with with people you care about, whether your patients or your children or your peers or yourself. These are broad categories for thinking about risk. And the next slide we'll follow up with responses based on the risk. I say that because any number of factors could move people between categories, and these are sparsing things out, dividing them up when it's on a continuum, of course. But if we think of low risk, the folks that we prefer it not happening, but we're probably not going to call them every day as a provider, or the vague thoughts. They've thought about death or not being here as a coping strategy, but they don't have the plan to harm. They're not thinking about wanting to die. They don't probably really want to die, and have a number of protective factors. But we elevate that when plans get more specific, or it becomes more chronic, or there's more access, or maybe some of the self-injurious behavior. Of course, stressors here can be significant. If we think about some of the general risk factors of suicide, they include, as Joe and Barbara talked about, psychiatric diagnosis, and Tourette being one of them, as Dr. McGuire covered. And of course, again, back to that iceberg model of all the things that come along with Tourette that are outside of the diagnostic criteria, the mood, the anxiety, all the complicating factors can put our patients, are the people we care about, at increased risk. Family and social factors are huge as far as predicting risk. Abuse, family communication or problematic family communication, conflict especially, sexual minority status, bullying, substance abuse, just to name a few. Older adolescents are at higher risk completing suicide. Adolescent females are 4 times as likely to report suicidal ideation, but males are 76% more likely to commit. So both genders are high risk. So I think, again, it's important to consider these as kind of rules of thumb, but consider the individual factors. And just again, some ideas of how we can respond. I've got a couple slides to talk about this. On a lower level, we want, with adolescents especially, to make sure families are involved and understand how to support their children. If it's a young adult, then it can be someone else in their social support network. Access to crisis hotlines, developing a help-seeking plan. I'll go into a few details on that next. Somewhere between low and moderate, I'm not against doing some of this. On even the low, again, my position on firearms is they don't belong in households with children, but even getting more, I've got a Amazon page bookmarked for vinyl knives and things like that for kind of folks in our moderate range. What I tell parents is, you knew where your Christmas presents were hidden. Assume your kids know where the pills are. Assume they know the keys to your safe, and they know how to get access, get them out of your house if your child has these means, and it just increased lethality risk. It doesn't prevent, but it can decrease. And of course, on the higher risk, that's when we're talking about ideally a voluntary higher level of care, whether that's a partial hospitalization, inpatient type program. Most states have some option. California, it's 5150. Florida, it's the Baker Act for involuntary evaluation for high risk folks who are refusing care and unable to judge appropriately for themselves whether they need it. Similarly, have I advanced yet? No. There we go. For risk of non-suicidal self-injury, get a rough guide. If we look kind of down the columns here, it's talking about frequency of distress and really the temporal proximity from the stressor of being what we're looking for here. These are, again, general rules. A youth with a history of cutting, but hasn't done so in a year, but has a terrible breakup and is outed as far as their sexual orientation, they're going to get bumped up in my personal risk assessment, even though it doesn't fit here. So these are general ideas of how to figure risk when we think about generating a plan, but use your own best judgment when it comes to your patient or your child. So I'll close with some numbers. But when we talk about generating a safety plan, this is different than treatment. We could spend a whole lecture talking about therapies for suicide. But in this, when we talk about a safety plan, we need to consider these following elements. First, what are the triggers? We're looking here at both kind of the internal, the emotional triggers, and the situational triggers, the external cues, things going on in the environment that are likely to generate these thoughts, this ideation. Similarly, just as we want to do in habit reversal therapy or CBIT, we'd want to get a sense of kind of what the, oops, see now I'm changing things without meaning to. Oh, let's see, previous. Look at that, I must have found the sweet spot on my touchpad. What are the urges? What are the sensations, the feelings? These could be physiological too, that kind of let someone know this is coming on and can do a better job of planning their resources better. Because sometimes it's some of my patients, it's the chronic ideation, but often it's this impulsive. It just kind of blows up, and everyone else is sleeping. There isn't a plan going on to mitigate. For these folks, if there's a better way of getting a sense of, hey, this is building, I should be ready, I should get my network ready. Likewise, we have internal and external coping plans to discuss the internal things that one can do from distraction. Unlike when we're treating OCD or anxiety, where we don't want to do escape, we want to learn to face fears and build a tolerance to these negative internal emotions. With suicidal plans, often those are more, well, the ideation could be chronic, the intent to follow through can be intense but sudden and brief. And so this is one of those cases that having a distraction tool or tools is indicated. And past behavior predicts future behavior. So if they've had something that's helped in the past, let's go back to the well. What kind of lit can we have ready for next time? With external, same thing. What's worked in the past? This can be what or who. who has helped in the past, and having, for all of these, that we have a documented plan written out step by step in multiple places. People that are supportive have copies of this, that it could be electronic for our millennials and whatever the next generation is, ready to go, including who to call and how to contact them. And we've already talked about having a plan to remove the means and have those means removed in the home. Now I can't advance what I want to. So I'll leave this up for a minute, but I think it's important we get these crisis hotlines out to our, really to all of our patients with any risk factor, even if it's not current. The giving them the knowledge that even if they don't have a relative, a friend that they want to reach out to, these are services available 24/7 by text, by phone. Often there are local numbers available too, depending on where you are. That it's important that there's a backup plan for our patients to have, even if they don't feel comfortable reaching us on our after-hours service or waking a parent or a friend up. But I will hand this back over to Joe to drive, but I wanted to thank everyone, and I think now is our time to field questions.
Wonderful. Thank you all for such an excellent presentation. So as Dr. Lewin mentioned, we're now going to begin answering the questions that were submitted during the presentation. As a reminder, you can still submit your questions through the questions pane in the control panel. If we are unable to get to everyone's questions, I see that there are quite a few here, so we might not get to everybody's. Just want to let you know that here at the TAA, we do have a full-time information and referral staff who would be more than happy to answer your questions as well by emailing support@tourette.org, or you can give us a call 1-888-4-TOURETTE. And if there's anything else, we will always reach out to our presenters to answer these questions. So the first question I have, and if you could really answer, for individuals who also have OCD, is the percentage of suicidal ideations higher?
Lewin, do you want to start?
I think I muted myself. Apologies. I actually don't know that I have a head-to-head comparison. I think if we think about combined risk, the more going on sometimes can be a higher load. I don't know that it would predict a higher risk above and beyond some of the other general risk factors, family conflict, lack of support, feeling excluded. I think it might be that folks with OCD have higher risk because of those factors, because they're more disconnected, they're more isolated. It's leading to more problems with relationships, with employment, versus necessarily a biological trigger. But I think certainly the kind of the combined load might suggest higher risk, although I don't think it's the OCD specifically. Dr. McGuire, any?
So just to kind of build off of that, the other thing to kind of think about with OCD, sometimes they'll have these harm-related obsessions, right? People will say that I'm really worried about harming myself, or I'm really worried about harming somebody that I love, or, did I just, they'll drive over a speed bump and express concern that they just, ran over somebody. So they get off the highway, they go back on and kind of check. So, when thinking about kind of suicidal ideations in the context of OCD, and tic disorders, it's important to kind of delineate between, these harm-related obsessions and more active or actual suicidal thoughts and behaviors. That's just my 2 cents. Dr. Coffey, did you have anything to kind of add?
Yeah, and I think going back to your discussion earlier of mediators in terms of anxiety and depression, OCD may also raise the likelihood of depression and rumination as well. So I think certainly we don't have a lot of specific evidence for OCD context of a tic disorder. We know clinically that these patients are often preoccupied with harm coming or doing harm to self. So I'd be concerned, certainly.
Yeah, I think the study I was talking about, this community screening, again, low rate of Tourette's and a lower than expected rate of tics, but we have several screening tools to look at suicidal ideation embedded in the battery, and probably somewhere out of the 500, I'm thinking 40 to 50 triggered an assessment, a further assessment, where we probe deeper. Of those, 5 kind of escalated to that moderate to high on the criteria I was talking about. So I bring that up because a lot of our studies on suicidal ideation are based on a screening question or a series of questions. When we dig deeper as far as risk level and kind of try to parse out sadness, or what Dr. McGuire was talking about, obsessional triggers related to death or dying, sometimes those questions don't adequately do it. So I actually think the impact survey did a fairly nice job at getting a little more specific. Sometimes I think what's hard to calculate comparative rates is the methodology varies, and so I think it's a great question, and it's hard to quantify because of the methodological variations in our research.
Great, thank you. I believe, Dr. Coffey, you spoke more in depth about the impact survey. The next question is, how was the impact survey recruited? Was suicidality reported as the survey main question when asking for parents to participate?
Yeah, I think, Angela, you may, from a TAA perspective, have more information than I do. No, suicidality wasn't a particular feature of this. This just happened to be included in many questions relative to quality of life of both adults with Tourette's as well as parents of children with Tourette's who responded. And as I mentioned, there was almost 1,000, I think 900 and some altogether, including the adults. So this just happened to be one of the many questions about sort of non-direct tic-related issues related to quality of life. It also, the context of in 2018 was the increasing epidemiological rates of suicidal ideation in young people and in adults as well. Certainly now with COVID, we have another wave of increase in suicide risk and actual suicides going on. So that may be something we want to capture in the 2020 survey.
I can just say from the TAA standpoint that we didn't necessarily have a recruitment process. It was more of us just pushing out the survey and looking for our constituents to answer it so that we could get a better idea of who our constituents are, what their needs were, and to gather this information to better serve them. And as Dr. Coffey just mentioned, we are looking to launch another one hopefully this year. So great. The next question I have, does self-harm typically lead to suicidal ideation or attempts, or not necessarily? What is the relationship? Also, what is the difference between self-harm and self-harming tics?
I guess I'll dive in there and let these guys correct me. Self-harm behavior, the non-suicidal self-injury, again, this is a behavior that the intent is harm, maybe pain, maybe relief, but it's not to die, does increase the risk for completed suicide. That's been looked at statistically. It's replicated. It's not causal. Most adolescents, most people that engage in non-suicidal self-injury will not attempt suicide, but it is an increased risk factor. With regard to the difference between the non-suicidal self-injury behaviors and tics that cause self-injury, tics that involve, well, I could go on for a long list, but for folks that might be newer to the Tourette community, tics that involve picking or pulling or hitting oneself in the head or even against objects. The difference there is the intent. Most individuals will report this as an automatic behavior that they are not intending in which to engage. It happens seemingly automatically and is difficult to control, just like any other tic. So I think again, the differentiation is in that intent. I'll let my colleagues correct or add.
No, just to add, I think that's very much on point, Dr. Lewin. Certainly, at least in the patients I see with self-injurious tics, there's this component of the just right phenomenon.
Yes.
Oftentimes they don't want to harm themselves, but they want to do it or feel it until it feels just right. And so that's a phenomenon that we struggle with to understand how to quantify and the metrics and where does it lie in the continuum between OCD and Tourette's. But I think that's an answer that we could often ask our patients about when they tell us about self-injurious tics.
And just to kind of close the loop on all of that with this not just right feeling or phenomena that relate to tics, this could be things, as you guys noted, punching in the head, even choking yourself. Usually these things are driven by an urge or a not just right phenomenon. Behavior therapy, just to put in a plug, habit reversal training, CBIT. If it's a tic, you're not doing this for the intent of suicide, relieve, suicidal ideations and behavior. You're doing this for an urge or not just right phenomenon. Behavior therapy, CBIT, habit reversal training will help patients manage those tic-related self-injurious behaviors. Medication, will help in most cases, I would assume, with those specific types of tics. Behavior therapy won't necessarily help address suicidal ideations and behaviors. And I think that that's an important thing to kind of remember, which speaks to the importance of doing good assessments that Dr. Lewin kind of talked about to differentiate those types of behaviors.
Yeah, and if I could just add, I was a site investigator for the TASL study, the treatment of adolescent suicide attempters, that was published maybe a decade ago. And we developed a specific CBT for suicidal ideation in that study. There was an algorithm of medication, and then there was a whole lengthy CBT for suicidal ideation. It wasn't at all related to Tourette's, but I think some of those findings could be applied to patients who were suicidal.
Great. So I have another question. We have time for a few more. I just want to say that we might not get to everybody's questions, but I will send your questions along to the speaker so they can answer them, because some of them are really great. So this question's a little wordy, so let me know if you need me to repeat anything. Many of my younger clients with TS express brief suicidal ideation when angry or raging. For example, they may say, "I wish I was dead." This ideation resolves when they self-regulate. Although concerning, this is obviously quite different than a depressed adolescent who has more pervasive ideation. Is there an attempt to separate brief anger-related episodes from suicidal ideation from other types of SI? I hope I didn't stop you.
Dr. Coffey.
Yes, certainly, as Dr. Lewin very nicely spelled out the details of how you assess risk and what you need to ask. Absolutely. I found many kids in my experience with my patients will, in the midst of one of their explosive outbursts, will say, "I wish I was dead. I wish I was never born. I want to kill you. I want to kill myself." So it's contextual. We have to understand that this is an explosion and a lack of regulation of affect, and that thought or that cognition needs to be put back in the place of an explosive outburst. Many times, almost all the time, kids are remorseful about these. Parents say, yes, I know you didn't really want to kill yourself. So we need to take those remarks seriously because they express the degree of emotional arousal the child experience. But that's a very different thing than, as Dr. Lewin was saying, the kid who has a plan, who has written a note. So that's where clinical experience comes in.
And just to kind of build off of that, that's also the importance of limiting, as Dr. Lewin said, did a really nice job with that, limiting access. Because those are the kids who, in the moment, they're not intentionally wanting to harm themselves, but in the moment, if it's right there, it reduces, enables or reduces, enables access to something where they could in that moment, in that heightened state of arousal, as Dr. Coffey is kind of highlighting, make a judgment or act on an urge or act on something that could have longer term consequences, even if they don't mean to do it.
Yeah, agree 100%. I think that's such an important question, and it's one of those targets that's not unique to Tourette, but I think it's probably overrepresented. Those high intensity emotional outbursts. It's difficult for a parent to ignore because it's not just the verbal behavior, the I want to kill you or I want to kill myself, but the physical level of arousal, usually with a pretty robust calming down, like apologetic, as Dr. Coffey said, but it is an appropriate target for early intervention. While it's not easy, can respond well if folks seek out help and aren't afraid to come in for that early behavioral therapy and physician evaluation.
Great, thank you. I'll leave you guys with one more question. What can parents do if their child engages in frequent self-harming, biting or punching, to discourage and prevent escalation?
So let me jump in here first, and then I'd love to get Dr. Lewin and Dr. Coffey's thoughts. I think going back to everything that we've kind of covered, I think the first question would be, is it self-harming, or is it one of these self-injurious tics, or is it another kind of another type of body-focused repetitive behavior, like nail biting or kind of something that's related to more of a sensory issue. So I think first understanding, not all behavior, is the exact same. So really, working with a professional to identify what is the kind of source of the behavior, what are the things that happen before the behavior, and then also what happens immediately after, to identify things that may kind of trigger it, and also unintentional consequences that result from it. But I'd love to get Dr. Lewin and Dr. Coffey's thoughts on that as well.
I agree 100%.
I'd say well said, Dr. McGuire. One needs a diagnosis to understand what the driving forces are, and then you can develop an intervention. But well said.
Wonderful. Well, thank you all again for such a great presentation. This is all the time that we have for our conference session. Once the session is closed, you will receive a survey on the presentation. We would greatly appreciate it if you would please complete that and provide your feedback. You will also receive a follow-up email within the next few hours with a link to view the recording of the session. Additionally, the session will be posted on the TAA's YouTube channel for those who are unable to participate today. CEU credits were also made available for this session at an additional fee. You can visit Tourette.org for more information on how to purchase and claim the credit. We encourage you to reach out to us about this virtual conference or for other ideas and suggestions you may have. This presentation was presented free of charge thanks to our generous donors. If you appreciated the session, we would welcome you to support the organization. Any amount will help. Visit us at Tourette.org to learn more and to donate. On behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. Thank you all again. Have an excellent afternoon, and please join us for the remaining sessions today.